Hi everyone. Thank you for joining us at the Happy Conference today. My name is Adebusola Adekoya. I'm an assistant teaching professor at the Faculty of Nursing and Health Sciences at the University of New Brunswick. And I'm excited to be chairing this third session of the EPIC Conference, Autonomy and Independence. Before we begin today's section, I would like to note the EPIC Conference sessions are taking place on Zoom from 12 to 1 p.m. ET every weekday until June 4th. We encourage you to attend all of the sessions. Check out the AgeWell EPIC Conference webpage to download the EPIC Conference program, which includes details on all the challenge area sessions. All right, I'll begin today's session with my short presentation on autonomy and independence, the autonomy and independence challenge area. Then we will enjoy two research presentations with a 5-minute Q&A following each presenter, followed by a moving the dial presentation featuring a supported startup. And finally, we will close the session with a general Q&A. So I'm so excited to introduce today's EPIC Conference presenters. We have Saiful Hoque, Opal Sparks, which was unable to join us today, and Rene Adams. They will present co-designing thermoregulating smart textiles. And also we have a presentation from Lily Wren Opal and Jim Mann will present ethical considerations of using virtual reality for older adults with dementia in hospitals. And finally, Maxim Baldock will highlight how Azimuth Medical is moving the dial by improving quality of life for Canada's older adults and caregivers. We encourage you all to use the Q&A box to ask questions, leave a comment on a question, and upvote questions that others have submitted. We also welcome you to use the chat. Please note that this session is being recorded and will be available for playback. Links to playback will be posted on the EPIC Conference webpage and the AgeWell YouTube channel. Should you choose, you can enable closed captioning for Zoom on the Zoom toolbar. Without further ado, let's begin with a short introduction to the challenge area of autonomy and independence. And that will be me. All right. All right. So, sorry, I can't really see the slides there. Allison,
It's on the first slide. Can I advance?
the first slide. Oh, okay. All right. I think I can see that. So, all right. Thanks, Allison. So, hi, everyone. My name, like I said earlier, I'm Busola Adekoya, and today I want to talk on the current challenges to autonomy and independence in Canada. Just kind of a quick definition of what autonomy means. It refers to the person's ability to make decisions about their own life, about their independence, and this involves the ability to live and function with minimal reliance on others. Doesn't mean that people don't need support, but they can live the optimal life with support from others. Although Canada values individual rights and freedoms, many Canadians continue to face challenges that limit their independence and autonomy. And in the context of healthcare, we have aging, disability, housing, finances, and access to services. Next slide, please. So autonomy, why autonomy and independence, why they matter? Autonomy and independence are closely linked to dignity, self-determination, and quality of life. They allow individuals to make personal choices, maintain control over daily activities, and participate fully in the society. These concepts are really important for all Canadians, including older adults, people living with disabilities, and individuals living with chronic illnesses. When autonomy and independence are limited, then the person may experience social isolation, poorer health outcomes, and reduced life satisfaction. Next slide, please. So several major challenges currently affect autonomy and independence in Canada. So first, we as we all know, Canada's is aging just like the rest of the world. So Canada's aging population is increasing pressure on healthcare and social support systems. We have many older adults who wish to age in place, but limited home care services and caregiver shortages can reduce independence. Second, people with disabilities continue to face challenges related to transportation, employment, education, and accessibility, despite having human rights protections. And I'm grateful that we have AgeWell, the organization, looking at how do we bridge this gap. And third, housing affordability and the lack of accessible housing can make independent living difficult for many Canadians. Finally, we see increasing reliance on digital services. You know, we have AI, we have ChatGPT, we have different AI now. And this can create barriers for individuals who may lack the digital literacy, internet access, or Wi-Fi access and assistive technologies. Next slide, please. So some of the challenges, I just want to highlight some of the challenges that we're seeing here. The healthcare access also significantly affects autonomy. Many Canadians can face challenges accessing family primary care providers that can be the doctor or nurse practitioners. Mental health services is another one, and specialized care. And we know with long-term care homes, even in hospitals, we know long wait times may delay treatments and limit individuals' ability to manage their health independently. Also, we see in rural and remote communities, we see healthcare shortages can further restrict healthcare choices and access. Another important issue that we are seeing here is informed decision making. So individuals must have access to understandable information, in fact, informed information and support to make any informed healthcare choices. But we can also see language barriers, health literacy challenges, and cognitive impairment that can sometimes limit meaningful participation in decision making, thus making the importance of support, meaning that support is very important. Next slide, please. Also, we have here socioeconomic factors. We see poverty. So not everyone earn good income. And we see income insecurity with jobs, not having enough jobs or being laid off at jobs. Caregiver burden, when there is no enough support for caregivers, when they are caring for individuals living with disabilities, we see the stress and the anxiety. Also, social isolation for some older adults, people living in rural communities, if there are no amenities, if there are no programs to support or to connect them to the community. And of course, the indigenous and equity related disparities, we know they are this when it comes to indigenous communities, some of the challenges that they are facing in regards to access to healthcare services, language barrier, in regards to trauma that has happened in the past with people who were in residential homes. How are we doing that? The Truth and Reconciliation. It's another program that we see in Canada, or an initiative helping to break that gap. Next slide, please. So to address these challenges, I just want to kind of quickly mention what do we need to do in future direction. Expand home and community care. That's really important. We need to improve accessible and affordable housing. Make sure that that is essential for independent living. Strengthen disability inclusion and accessibility. Also increasing digital and health literacy supports. And promote person-centered and culturally safe care. Again, very important. Next slide, please. So in conclusion, autonomy and independence are central to health, dignity, and participation in society. However, many Canadians continue to face challenges related to healthcare access, aging, disabilities. Also, we see home and social inequities. Addressing these issues require collaborative efforts across healthcare, government, and communities, organizations for older adults, for people living with dementia, and to ensure that all Canadians can live with dignity, choice, and independence. So thank you so much for listening. And we're going to go to our presentations and hear more about some of these challenges and the solutions that we are in. All right, so we are moving forward here. I would like to I would like to turn things over to our to our presenters for the first presentation. We have here Saiful, Hoque, Opal Sparks is unable to join us, and Rene Adams. And so Dr. Saiful Hoque is a materialist scientist, textile engineer, and postdoctoral fellow at the University of Toronto and the KITE Research Institute at the University Health Network. After earning his PhD from the University of Alberta in 2024, his research has focused on bridging textiles and biomedical applications. His current work focuses on thermoregulation and physiological monitoring through smart textiles. Dedicated to community engaged science, Dr. Hoque champions co-design initiatives to ensure technical innovations directly benefit older adults and caregivers. Alongside his academic research footprint, he currently serves as the president of the Institute of Textile Science, ITS Canada. Opal Sparks, though not here, is the co-founder of Centro de Medicina Natural and an art group facilitator at Roncesvalles United Church. I'm sorry if I pronounced that incorrectly. Our current projects include the MAPS Community Expert Group, Dawn House 1 and 2, and Community Substance Use. In poverty research, Opal has worked with the Daily Bread Food Bank, Worsley, Colden, Tamarack, St. Stephens, St. Jamestown, Co-op, Nonviolent Communication, Atchison, Maitrey, CAMH, Access Alliance, United Way, the Stops Advocacy Project, Food Share, Take Back the Night, People's Blueprint, Social Planning Toronto, and Dr. Gary Bloch's Poverty Health Initiative. Wow, quite a lot there. She has spoken for the United Nations and is the recipient of the Queen's Diamond Jubilee Medal and the Rosie McGrorty Award. And next we have Rene Adams, is currently a student in the Community Health and Social Medicine Care Worker Program at the Mechiner Institute. With a background in advocacy and community work, Rene utilizes her experience of marginalization and disability to inform her work as a community expert and patient partner in health equity research in association with the MAP Center for Urban Health Solutions at Unity Health. She participated in outreach for the first sleep apnea study in Toronto's shelter system, in addition to thermoregulation and diagnostic textile development research with KITE-UHN. Rene also serves as a social medicine advisor to the Gatosol Center for Social Medicine at UHN. So I would love to invite Saiful and Rene to share their screen and give their 10-minute presentation. Thank you.
Thank you so much, Bosila. Thanks so much. I'm going to share the screen. Is my screen visible?
Yes.
Yes.
Okay, perfect. Thank you so much, and thanks for the excellent presentation and inviting us to present our work at Agile EPIC conference. So good morning, everyone, or good afternoon, based on the location where you are right now. Welcome to our presentation on the co-designing of thermoregulating smart textiles. I'm the Saiful Hoque, and I'm honored to be co-presenting today alongside community expert Rene Adams and also community expert and advocate Opal Spark. We are presenting KITE Research Institute at the University Health Network and working under the leadership of Dr. Adebusola. So before I start, I want to start the presentation of the technical part. I want to talk a little bit about the background, why we started this work, what is the motivation. And when I first saw this graph, it was a little bit scary for me, apart from the experience we see with the global temperature fluctuation. As you can see, starting from 1850, the temperature was kind of steady until 1900. And after that, we are observing a spike of temperature increase. And if you see on the far right of the temperature range for 2026, the prediction is still very alarming. And we are feeling it, like summer is here and the temperature is really getting warmer day by day. And these extreme weather events become more frequent and more effective for people who has different issues. And as we age, we have different medical condition as well. And I had the chance to talk to a few individuals who had problem with different thermoregulation issue, not warming, feeling warm, also feeling cold in different times. So that's how we started this project to mitigate this issue and to figure out a problem which is very close to our human body through textiles. If we can help people to remain better, to keep themselves warm or keep themselves cold based on the need they have. So that's how we started the work, and we consulted with several individuals, and luckily we were able to partner with Rene Adams, who will take you over for the next part of the presentation.
So thank you, Saiful. When we think about temperature perception, it's deeply personal to me. So for me, I often feel cold. And if I'm exposed to cold, it could take me up to 4 hours to start to feel warm again. This is significant because it affects my daily life. And it affects my mobility at times. If I'm cold, then my joints are hurting me and it stops me from doing a lot of the activities that I would normally enjoy. Often I'm finding myself going to bed with a hoodie at night to keep my heat in, or even in the summertime, using 2 blankets on top of myself just to stay warm. So I'm one of those people who really doesn't have a need for air conditioning, despite the temperature fluctuations that you've pointed out, Saiful. And also, I find that as we age, our skin gets thinner, so that makes me feel colder at times, or my perception of cold is greater. So we'll move on to the challenge of autonomy and thermoregulation. Continuous body monitoring of body temperature. Most commercial wearables are quite rigid, and smart textiles are non-invasive and they could fade into everyday clothing. It's important to measure core temperature to get a picture of what's going on in a person's body. So to test this, our engineering team developed a proof of concept for temperature monitoring smart textiles. The technical success came when we conducted validation testing to see if we could accurately monitor the skin temperature alongside core temperature. From a purely technical standpoint, the prototype worked well and successfully tracked the necessary data. So we'll move on to the barriers and the reality check. However, the reality check here is the adoption depends entirely on the garment level acceptability, and which conventional engineering often misses. And our survey findings found that for end users, the results are telling. While the tech worked, users rated the garment's comfort with a mean score of 3.44. And its maintenance with a mean score of 3.44 out of 5. So in pivoting, the participants were not happy with how it felt or how to care for it. To fix this, we realized we needed to look at a multi-stakeholder evaluation protocol to surface real-world requirements. And this is where Opal would have stepped in to help with the co-design sessions.
Yeah, thank you so much, Rene. So actually, Opal was not able to make it today, but Opal helped a lot with the co-design session. I'm going to cover the part Opal was supposed to present. So as Rene mentioned, we designed a smart textile which can monitor body temperature. In terms of the body temperature, we mean that skin temperature. So the core body temperature usually remains around 37.5 degree plus minus 0.5 degree, but it really the skin temperature which fluctuate a lot depending on how much sweat we have. In different location also we have different types of skin temperature perception as well. So we tried to figure out a multi-site multi-site skin temperature monitoring thermoregulating textiles. We developed it, we validated the proof of concept, it worked, but we did a short survey as well with the participants to see if they like the textiles, where they had a high preference for this type of technology. As you can see from this slide, the comfort was not rated that much high, although it was some people said it's too tight. The maintenance, they thought that it would be very hard to maintain. And that's how, with the help of Opal, we did our first co-design session to develop this type of smart textiles. And we had 22 participants, which included older adults, included formal and informal and formal, both type of caregivers, and also licensed health care providers as well, to get the overall perspective of different types of stakeholders. And in the co-design session, there are few priorities which came out most. The first one related with the maintenance, washability. A lot of participants, including caregiver as well, was mentioning the garment should be machine washable. Like if there is any sensor or something that should be washable, otherwise they are not willing to buy it. Another interesting finding was having like they want to have some soft material, and majority of the participant mentioned that they don't wear anything if it is with synthetic fiber. It was a little bit surprising for me for being in this background, because there are some other synthetic fibers which can increase the functionality of wicking so that your sweat can go out very quickly. But the higher choice was for soft materials, and pricing and the durability came frequently during the discussion. If I say a number, some people are saying that if it is like around $40 and it should last for 5 years. And if it is around $20, the t-shirt should serve the purpose for at least 2 years. So it was a good consideration for the future iteration as well, for us to think about how to minimize the cost and make it more accessible. We also talked about sensor placement. In our prototype, we had 6 different sensors, but we also asked them in which location they want to have the sensor and in which location they do not want at all. So as you can see from this figure on the left, they said probably in the chest or in the arm, they will prefer to have this type of sensor, but not in the armpit area because of the hygiene concern and also discomfort. And some people said not in the feet as well because of the mobility issue, because we are focusing this technology for older adults, and a lot of people might have mobility issue, and that's why they said they prefer to have something which is easy to take care of by them or the caregiver. And also they prefer to have a larger opening, adaptive clothing style, so that it's easy to don on and don off. So the prototype we had was actually a t-shirt style prototype. So a lot of people also talk about maybe a t-shirt is not a type of dress everyone will prefer. So we're thinking about that as well, to including some additional adaptive features so that it's more user friendly. So with this co-design session, few of the themes came up. One of the theme was like the garment should disappear with the normalcy so that it doesn't look like a medical device. And also, as I mentioned a couple of times before, the maintenance was one of the highest priority to purchase or to use these garments. Another theme was to have the trust. If the data is really reliable, how this has been validated, how many participants was there. So these are the questions or the themes came frequently. Also, as I mentioned about adaptive feature, a lot of people mention about prototype must be able to adapt different body sizes, and also it should be affordable and durable. And in terms of the fiber selection, as I said, majority of the participant, I would say more than 90% mentioned that something come with the natural fiber was more preferable. So as a next step and the future work, we are currently developing a new prototype, actually developed the first new prototype. We didn't validate it yet. And we're going to have another session to get some feedback from the participants, what they think about the new design and what to do next. And at final, our aim is to have a take-home study with this thermoregulating smart textiles and having the features of the thermoregulation as well. So that's all from my side for today. Thank you so much.
Thank you so much, Saiful and Rene, for your great presentation. Thank you. So we have a couple of minutes that we can use for taking questions, and I already have one question here. Just a reminder for people to put your question in the Q&A session. And so there is one question here for you. What impacts of global and local too temperature fluctuations on health and well-being of older adults from poor and low socioeconomic groups of population? So this question is asking about what do you see as impacts of global and local temperature fluctuations on health and well-being of older adults from poor and low socioeconomic groups of population? And this from Shirley.
Yeah, that's an excellent question. Thanks so much. And please let me know if my answer is not going into the direction of the question. So if I understand well, you are asking what's the impact of this temperature fluctuation of the particular group of people who have low socioeconomic structure of the group. And my answer is actually, that's why we're trying to develop this type of technology. For instance, having an air-conditioned facility, sometimes a luxury for the people who live in far areas or doesn't have that much of access to this type of technology. So we're trying to develop this technology so that your garments can work like a air conditioning tool. So the garments can cool you and the garments can warm you as well. But how to do it? Before that, we have to understand if you are cold or warm. That's why we're also including the temperature sensor as well to know how the body skin perception is going on. And based on that, the garments will have the capacity to include the air conditioning capacity or the warm up. And we're trying to do it as low cost as possible. So if I talk about our first prototype developed, the costing was less than $15, if I say, with the sensor and with the garment. So we're trying to minimize the cost as much as possible. And that's why in the code design session, actually, that was one of the prompt question as well, like how much cost it seems affordable.
Thank you so much, Saiful. For the sake of our time and to move things forward, we have, excuse me, a few more questions, but we're going to get to that later. But we have to move forward now. Thank you so much for your beautiful presentation, Saiful and Rene.
Thank you.
All right, so we are moving on to our second presentation, and I would like to turn things over to Lily Rain and Jim Mann. So Dr. Jim Mann is a researcher living with dementia and is a strong advocate for which he received an honorary Doctor of Laws degree from UBC in 2020. His focus includes one, technology used to benefit people with dementia living in community, long-term care, and hospitals. Second, the meaningful and ethical engagement of people with dementia. And third, reducing the stigma for people living with dementia. As a recipient of numerous awards, Dr. Mann is Also an impactful knowledge translator with 80 sole and co-authored publications in respected journals, scores of presentations at major conferences, and 14 recorded podcasts and 30 webinars. Whew. All right. And Lily, Lily Rene is a PhD candidate in interdisciplinary studies at the University of British Columbia, supervised by Doctors Lillian Hung and Ben Murchison. Our research focuses on the ethical considerations of using virtual reality for older adults with dementia in hospital. Since joining the UBC Innovation in Dementia and Aging Idea Lab, Lily has led more than 10 projects, exploring how technology and environment shape dementia care across care settings. Lily has 26 publications and more than 80 conference presentations, many of which were co-delivered with patient partners and family partners. Meaningfully engaging diverse partners is always at our heart. That's so beautiful. All right, I'm going to invite Lily and Jim to share their screen and give their 10-minute presentation now. Over to you, Lily and Jim.
Thank you very much. I have the honor to work alongside Lily on this important project because ethics is a very big priority for me. And so I am looking forward to talking about this issue for everybody's information. And I think Lily tells a good story here. But to introduce the presentation, VR has shown to improve the well-being and the socialization of older adults with dementia in many settings, and long-term care and acute care. And but up to now, most research projects have gone into the feasibility, but haven't really looked at the at ethics, at the ethics of actually using VR with patients in hospitals. And so the work that she is doing is really, really important. Ethics is not just one question: is it right or is it wrong? In fact, it is dynamic. It is situation specific and research project specific. And I think the important role is always including the person that would in fact use VR. It's about actually seeing the person beyond their diagnosis. And the bottom line is who determines that they are capable? And that's a big, big question that is being investigated. So the questions that Lily is pursuing are the next slide. What are the many considerations in the use of VR? What are the questions that need to be asked? And once you ask them, what are the strategies that make VR use in acute care relevant and safe? And it has been a fascinating study because, as you see at the bottom, there are 3 types of VR that are being used: the goggle and the stationary projector on the wall, and the mobile projector for patients not able to leave their hospital room. So, with that, Lily.
Yes, thank you
Start
very
your
much,
presentation.
Jim. Yes, I just want to say I feel the same. I'm so honored co-presenting with Jim, and this can't be done without amazing support from my supervisors, older adult partners. I know, for example, Lily Wong is here listening to our presentation, and many of our lovely participants. So moving to research methods, this study adopted a participatory approach. So we used purposive sampling and just recruited people from diverse groups, people living with dementia, family caregivers, multidisciplinary frontline staff, care leaders, ethicists, and VR industry partner. And our data collection method are mainly co-creation workshops, interviews, videos, and field notes. Data analysis is guided by reflexive thematic analysis. So here you see a screenshot of one of our co-creation workshop. So we identify 3 interconnected themes for our findings. The first theme is about knowing the person and engaging meaningfully. So ethical considerations identified here are, first of all, seeing a person with dementia as a person. So for those of you who know Jim, like this is what Jim is highlighting all the time. Understand people's needs and preferences and offer VR in the right way. And how to address these considerations include check care plans, work with family caregivers who may know the patient more, communicate with the patient, and do not assume what could be good or bad for this person. And of course, we should always respect the patient. So we have a lovely quote from Jim here. And Jim, if you want to read out yourself, and yeah. Okay, yeah. Okay, I do
So
that.
you go ahead.
Sure. So it is important to know that every person with dementia is different, and their needs may change from moment to moment. Communication is the key. We can offer patients new videos, and if they like watching the same old video, we respect that. And theme 2 is about understanding the bodily cues and support the expression. The ethical considerations here include paying attention to the facial expression and body language of the person, and also support the person with language impairment or language barriers to communicate with staff. So we have a family caregiver who said there are people who prefer enjoying just watching VR alone or without conversation with staff. So, or maybe they don't want to explicitly say that I am done. So we can tell them upfront that, hey, it's okay if you signal me. What would you prefer in today's VR session? And another quote from our frontline staff, she said, I use translator to communicate with clients who do not speak English when offering VR and watching together with them. So here we're talking about she used innovative tools to facilitate her communication with patients. So other points brought up by people from our participants is give options for people to express and work with family caregivers again, who knows more about the patient than the staff. And the third theme is embedding into everyday care practice. So ethical considerations here is just to think about the manpower and the team culture, which can shape the ethical VR delivery. And researcher staff collaboration also need to be strengthened to support this ethical VR delivery. We have a frontline staff said something very practical. To me, ethical use of VR is offering the technology at a time that works the best for the patient. But in practice, although patients tend to be more energetic in the morning, we are all busy at that time. But you researchers can come in the morning to try with our patients. And the how here is about co-developing practical tools that can be integrated into workflow. And it's also about consistently support staff in making moment-to-moment judgment. So a frontline staff told us, in our unit, we're short-staffed, so we will need to work with you, researcher, to deliver the VR and provide the technical support.
But some people, even in acute care.
Yeah, I would like to quickly share a moment that Jim shared in the co-creation workshop and about the message he really wanted to highlight.
We're not necessarily going to know what do you want to, because they've never used VR or it's been very limited and they don't know the possibilities. And so in a lot of cases, you are relying on the care staff to really have a sense of who they are working with in order to have a really good, positive experience.
I think, yeah, this is a nice reflection of like how do we deliver it and who do we involve, how to communicate. So to conclude, ethical use of VR involves recognizing ethics as relational and addressing the embodied, both verbal and nonverbal expressions of that patient. And ethical considerations and mitigation strategies need to remain adaptable within dynamic and a complex dementia care environment for feasibility. So thank you very much, HWell, for having us and all the funding agencies who support me doing this study. And of course, thank you so much, UBC. So I will stop share and we look forward to your questions.
Thank you so much, Lily and Jim. That was a great presentation. I'm trying to look at the Q&A here. So while we're waiting for people to type in their question, I really love your research, and I will ask you a question if that's okay. In one of your themes, you talked about a participant that mentioned the use of a translator to communicate. I just want to ask about some of the ethical concerns that might come up with the use of a translator. Sometimes people talk about family members not wanting to be upfront and share things with individuals, especially if the news is really bad or it's something that they don't want their family to know about. And I just wanted to ask if you have seen if there are any ethical concerns or consideration with the use of a translator. And another one is that with the use of a translator, you're supposed to use, or interpreter, you're supposed to use like a professional when it comes to because of differences in how people interpret things and perceive things. So, have you seen any ethical concerns, or are there any considerations at all when with the use of a translator?
Jim, if you have any thought here, like please go ahead. Okay. So yes, the staff brought this up because she's Filipino and she doesn't speak Chinese, and the patient she give examples speaks Chinese. So yeah, we that's a very great point, Busola, and I think because I know that unit is short staff, so probably it takes time to coordinate, have a translator come to here, and all the time 24/7, which is a bit challenging. So that's why the easiest way for staff, and also she's a younger generation, so she's comfortable using the phone to download that translator and hopefully to facilitate this lively conversation. But it's very good point. And it, again, like Jim said, it's so situational because we have also seen cases that families themselves can be the translator. So it's really complex here, but there are also patients whose families are overseas, not reachable. Yeah, so I'll need to work more on this part and dive into more. It's just bring up some contextual information there, like why the staff brought up this point. And I think it's very practical because in BC, we are increasingly diverse, also seen among older adults, those with dementia. So it's very important point. Thank you so much. Yeah.
Yeah, no problem.
Yeah.
Thank you so much, Lily. And we'll leave the question for another time. All right, so we're moving on here. And right now, I would like to turn things over to the Moving the Dial presenter, Maxim Baldock of Azimuth Medical. Maxim Baldock is the CEO and founder of Azimuth Medical, Maxim has a bachelor's and a master's in engineering and founded Azimuth after his grandmother fell and broke her hip. That experience set him on a mission to protect older adults from the devastating consequences of falls. Today, he leads a Montreal-based team bringing air secure to retirement homes across Quebec and Ontario and building the technology platform behind the next generation of hip fracture prevention. All right, I would like to invite the DAO presenter to share their screen and give their 10-minute presentation and demo.
Fantastic. Thank you very much. Thank you for having me. So I know we are at the end of this session today, so I'll keep it quick and concise. As mentioned, my name is Maxime. I'm the founder and the CEO of Azimuth Medical. And today I'd like to introduce a bit Azimuth Medical, our technology, the way we have developed it. I think you may see some overlap with the previous presenters. And I think that is very interesting because we are more on the business side of things, of course, as being a business, but we integrate many research-based techniques that you already have seen. So little preview here. Statistics of older adults, I think this is we're quite familiar with this, but looking especially at falls and injuries caused by falls, hip fractures are quite impactful in the lives and autonomy of older adults. If we look at the overall North American portrait, we have a third of a million of hip fractures every year. So it is quite a big problem. These hip fractures cause death, yes, but there's also a big rehabilitation portion and a big societal cost. So all of these things combined is quite impactful. Women experience most of these impacts as most of the osteoporosis kind of diagnosis are women as well. And they make up quite the majority of the residents of senior care homes, older adult care homes, and long-term care. Now, currently, what we're trying to do to prevent these falls, these injuries, this kind of escalation of losing independence are kind of the solutions presented here. Usually we have floor cushions more in a hospital-based long-term care setting. There's lots of technologies for fall alert. Some of them are intrusive, some of them are not. There's other presenters that are speaking later this week, a company called Living Safe that do sensors for fall detection much more, and they are kind of positioned in the space, so it's not intrusive. So very interesting technologies here, but saying that these technologies are kind of monitoring, but it's difficult to prevent these injuries. So that is why technologies have been developed in the past and are currently being studied, kind of these air belt or class protectors, which are airbags within a belt, essentially. Now, this touches to a point that was mentioned previously. One of the key important factors when we looked at these kind of smart textiles, comfort was very, very important. Not only comfort, but kind of visuals. Is this stigmatizing? Now, when we look at these technologies here, well, you could say that these are quite visually intrusive, maybe not that comfortable, and could be stigmatizing. So to kind of address this, we went through a proper channel of questions. We interviewed older adults, we interviewed researchers, clinicians, physiotherapists, and so forth. We did a kind of design lab with CTAN, and we kind of arrived to the conclusion where we published our first kind of preprint of testing. We did some pilots and we tested the below garment here, which was one of our prototypes. And we asked some very specific questions, right? How easy is it to put on, remove? Is the comfort aspect of the fabric important? What is it sitting down, walking, and all of these kind of metrics. Now, what we saw is that we had, I think a well-designed garment because we had over 4 out of 5 for the majority of the scores. One important thing I'd like to highlight, however, is that weight aspect, which has a mean of 3.2 out of 5. Very interesting that older adults kind of look at garment and they think and they anticipate something that is very light. And so when you introduce something that has more weight, they kind of are refractory to that. It's interesting because we never consider the fact that we put our cell phone to our pants. If you take the pants with a cell phone in it, it is heavier, of course, but it is not something we do. We always, touch and experience garments when they are empty, when the pockets are empty. So interesting kind of fact there. But what we did is that we developed a further prototype, kind of this intermediary thing here. But at the end, what we did is that, getting all the feedback, we produced a membrane in a trouser version of our product. So this is a airbag membrane that has onboard sensors. The sensors analyze and detect when a fall is occurring. What it is, you can see that the replaceable CO2 cartridge inflates and this membrane inflates. So you can see here kind of an inflation and how it looks like. And what we did is that we validated this portion as well, and then we arrived at the same kind of conclusions where when it is not inflated, it is invisible. When it is, it has protection. So this was quite important. We'll show a little preview here of the airbag inflating. So this was quite important to have a visually, kind of invisible garment. Here we go. So what we did is that one of the key aspects of detecting and predicting falls is differentiating a fall from sitting down, right? That is usually one of the triggers of a false positive. So what we did is that we trained on real life falls. Now, this also touches to another part of the conference that was just presented, the ethics of essentially tripping older adults and making them fall. I know that the KITE Institute has a big lab on this, but what is interesting is that when we look at how do we train a model with real life falls in situ and a database that was, generated in a laboratory, this has lots of challenges to make a kind of an algorithm that is generalizable from older adults falling and younger participants emulating a fall of older adults. So you can see there's quite an interesting nuance here. Finally, the health economics of this type of device are very important as well, right? We look at acceptance metrics that is kind of on the user level, but the unit economics are more at a broader level. When we look at hospital-based long-term care, this needs to make sense financially. So this is quite of a big calculation. The goal here is when you introduce an innovation that does prevention, it needs to be financially viable. Of course, usually, prevention is financially viable, but this needs to be studied, this needs to be documented, and this needs to be proven. So we are doing that in the first in Canada pilot trial of our smart inflatable hip protection. So our product Air Secure is being tested in a Envisage trial in a hospital-based long-term care in Quebec. And that is very, very exciting. So thank you very much.
Thank you so much, Maxime. Very innovative. And I would like to invite all the presenters to join me on the screen as we move on to the Q&A session. And so we have some questions here. I would like to start off with a question for you, Maxime, from Nathan. The question says, as well, how widely has this technology been adopted within Ontario's retirement home and long-term care sectors? Approximately how many homes are currently using it, and what kinds of operational or implementation challenges have organizations encountered?
Yes, so a great question, Nathan. We have one client in Ontario. It's a private older adult care home. It is not a hospital-based long-term care or long-term care facility. That is one of our clients in Ontario. We are working with home care based services, which is kind of another angle to that portion. One of the key important aspects of integrating into older care homes is how do you manage equipment, right? There's many ways you could, older care home could buy, a retirement home could buy equipment and manage the equipment themselves. That is like one part. There's another part where we could lease the equipment and then it could be distributed to older adults. It could be a direct azimuth to the residents kind of relationship, skipping the retirement home. So there's like multiple ways to do this. One of the key aspects was how do we clean these garments? The way we have built the product, and that was referenced as well in the other conferences, how do you clean this garment? Well, the membrane zips out of the garment, so you can wash the trouser separately in any kind of automation washing machine. It can reintroduce this membrane within the trouser as well. So it can then fit into the realities of either hospital-based long-term care or retirement homes.
Great answer. Thank you so much, Maxine. We'll move to another question here. I believe this question is for Saiful. And how can you make the garment and wearables now, yes, washable? Is there an phone app to monitoring the temperature connected by Bluetooth?
Yeah, thanks so much. And that's an excellent question. And I guess this is one of the major question all wearable researcher get. So one of the solution is having encapsulation. So the sensor we encapsulate with water impermeable polymers, and that's how you can still put the wearables like the garments in the washing machine, and it doesn't affect the sensor itself. So we're placing some water impermeable polymer so that sensor doesn't get destroyed. Regarding the monitoring of the temperature through app, that's what we are developing currently. We didn't implement it yet, but we have the microcontroller, and now we are developing the graphical user interface and the app. But that's an excellent question. Thanks so much.
Great, wonderful. We still have a few more minutes here, so we can take one more question and or maybe a few more. And this question is for you, Maxine. Could you speak to how the garment detects when a fall has occurred? For example, does it rely on motion sensors, impact detection, or AI-based monitoring? In addition, from a caregiver and older adult perspective, how easy is the garment to clean and maintain following incidents such as incontinence or prolonged wear?
Yes. Okay, so the first question here is there's like two questions. I think I've touched on cleaning the garment in my previous answer. I'll go on the fall detection. So in the membrane that you saw, we have embedded IMUs, so inertial measurement units. They are sensors that measure acceleration, speed, orientation. We use a technique called sensor fusion, where we have multiple of these sensors within the membrane, and we have a microcontroller that is on board that parses through this data in real time, and it's kind of a mix, right? Because a fall is not linear. It's kind of there's twisting motion, there's falling motion. So we have this machine learning algorithm that differentiates a fall. What essentially it is, it's fall prediction, because a fall detection would be confirmed by an impact. We have to pop the airbags before you hit the ground to protect the person from the impacts of that fall. So that's how it's set up. It's a bunch of IMUs that we analyze in real time on this microcontroller, and then we signal the airbag to inflate when we have confirmed that the person is kind of mid-fall. Hope this answers the question.
Yeah, thank you so much. We'll wrap up very soon, but was wondering if Opal want to respond to what's your motivation for undertaking, being involved in research. Opal, are you able to take that?
Thank you for that question. As a senior who has congenital issues that I'd like to learn more about, one of the reasons why I got involved in research was to learn more. And as a melanated person, we often have problems in receiving optimum or reasonable care. So in terms of the research, there are many people like myself who are racialized, who are involved in research. So it's a friendlier venue to be involved in for research. So that is another thing that makes it a positive opportunity for me. And in terms of being involved in research, one of my interests are also being involved with people who are homeless slash unhoused. We're just being led to be involved in the issues that people that are unhoused live with. So thank you for that question.
Thanks. Excellent. Well, this is the end of the session, and I would like to thank everyone. Thank you so much for joining us, and to the presenters for your great presentation. And we would like to thank Joel for hosting us and organizing this. And I hope you keep in touch, everyone. If you have further questions, you can email Joel. All right. Take care, everyone. Lovely to see you all. Bye.
Thank
Thank
you.
you.
Thank you.